Welcome, everyone. Welcome to the HSPN OHT webinar for Ontario Health Teams. This month, our topic is measuring patient and provider experience. Finally, to be completing the quadruple aim. Such a pleasure to have you with us today. We have over 500 people have registered for this event. I see we're at about almost 250 have signed in now. Please, we like to start by having everybody type into the chat to all panelists and attendees. We're going to put warning signs on this. You must click. Automatically, it only comes to panelists. You have to make that special click on to panelists and attendees and let us know who you are and where you're from. Daryl from KPMG, welcome, Daryl. We have, oh, this is when they come really fast. Jen, Polly, Suzanne, Lori, Ann Payton, Sarah from Windsor, Anna Crawford, St. Mary's, from Kingston, from the Regional Geriatrics Office, Mount Forest Family Health Team, Gabriel Sander, Melinda Gilmore, welcome. Abigail Scott from Frontenac Lennox Addington. Okay, Dean Valentine, welcome, Dean. Really happy to see you here. We saw you last week, one of our focus groups. Leela from North York, Toronto Health Team. Francine Williams from Hamilton. Leslie McGough from Trillium. Olga McNeil from Northern Ontario Health Team. Daniel Srivar, Brantford. Charles from Ottawa East. Wendy, oh, so many of you are typing just panelists. I just got to see Wendy, you were just a panelist. Charles, just a panelist. Please take the time to click on the two panelists and attendees. Teresa, you were just a panelist too. Okay. Thank you. Allison from Niagara, Lori from South Riverdale, CHC. And when we get into the chat a little later on, it's really important that you're typing into panelists and attendees so we can have a conversation. Otherwise, you're just streaming into the bot at the other end. Welcome, Judith from North Durham Family Health Team. So keep coming in. Please keep telling us who you are. We're over 300 people now have signed in. Welcome. It's our great pleasure to be bringing you a great panel today, as well as some really interesting topics for conversation. Some of it may even be a little bit controversial. We'll see how things go. We always appreciate our place and where we're coming to you from. And we wish to acknowledge that the land on which the University of Toronto operates. I'm speaking to you from the University of Toronto on College Street in Toronto. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. So, you asked questions, many of which we get to. In fact, we checked last month, and last month with the support from PGLO and Ontario Health and others, we think we actually got to all of your questions. But we had missed questions from the last chance that we were speaking about patient and provider experience. And here are a couple of them that I'm just going to bring up and address, some of which we'll get to talk about today, some of which are really vexing questions. So, are there model questions that cover the 4 areas of patient experience? That was one, and another attached to that was, where is outcome measurement? This came from our January event when we were talking about the quadruple aim last. How can there be commitment from all OHTs and partners to collect sociodemographic and race-based data? And how do you interpret experience results in light of unusual events? For example, a pandemic, which could skew the results at a particular point in time. So these are some of the questions that you had for us. On the first one, are there model questions? And this was addressed originally to Carrie Koleski, who was introducing our framework that covers the 4 areas of experience. And where is outcome measurement? Well, today, this webinar is your answer. We'll summarize key questions to cover those 4 areas of patient experience plus transitions, plus outcomes, plus the outcomes of patient experience. So I think you will feel that at the end of the day, and if you don't, that you think there are gaps in coverage, let us know. Here's a really important question, and particularly salient and raising in importance in our times. How can there be commitment from all OHTs and providers to the collection of sociodemographic and race-based data in order to have this data from providers to regional leaders at levels across Ontario? So we don't have very good data collection mechanisms on this. We don't ask race-based data at many intakes. Community health centers are at the forefront, but still represent a relatively small proportion of all patients in the province of Ontario, even though they can be very important in Ontario health teams. So we are going to directly ask. Our survey measures will include race and ethnicity questions, a bit of a hybrid, because if you want full race or ethnicity, there are many, many options. And we're trying to keep it down to about 6 or 7. We're also going to ask sociodemographic data from patients. And our purpose here is really just to start to accumulate and report on these measures to see whether there are differences. We did some surveys with home and community care clients about 1.5 years ago, and we found there were differences amongst individuals that reported isolation. They had lower overall experience scores than those who were less isolated. So we have some questions like that, and we'll talk about some of those in minor detail today. And finally, how do you interpret experience results in light of unusual events? Well, this is a most vexing question. We can't change the events of the past year or 1.5 years, and we still have a ways to go. And there is absolutely no way to extract responses on the effects of the pandemic on any responses out from other experiences. I think the best that we can do is to collect the data, provide the context, understand, and monitor as things are changing in this rapidly, hopefully continuing to change now for the better situation, to see where we come out of and as things stabilize. We're in this for the long haul, and I think that it's going to be really important for us to keep this in mind and bear this context in place. If other people have thoughts or comments to add into the chat, feel free to provide your reflections. These are some of our thoughts on some of the questions that came up that weren't directly addressed in our prior events, and we'll continue to bring this to the fore. So, first poll we love to take is whether you're joining us for the first time. So I will launch this, and if you can just click in yes, you've been here before, or no, this is your first event. We always find that with over 500 people signing up each month, I'm kind of like, this has to be the same crowd, has to be the same crew. Some people still voting in, you're getting very quick at this. 20 seconds, 75%. The first time I did this, I think it took us 2 minutes to get to 50%. People have gotten very, very adept at responding here. A couple more, and people are coming in now. Have you joined us for an event previously? And I'm going to close it off in 5, 4. Okay, that's time. And this is interesting. 82 new people. That's almost 100 new people here just joining us today for the first time, and you haven't seen one of our events before. We've been doing these, we started in December of 2019, but we've been continuous since last September. Every month we have this event, and we are talking about Ontario health teams and things that could help Ontario health teams in advancing towards the goal of population health and person-centered care. So welcome everyone, and especially to our new individuals. We are very active in the chat. It's the first time joining us. Get ready with your keyboards and the chat box, and be sure to check to all panelists and attendees. We welcome chat throughout the event, the entire event. And today we are so privileged that we have with us some representatives for the groups that we're talking about. Chloe Gallagher is a patient advisor of the Burlington, Ontario Health Team, has had many experiences over the years. We'll introduce her in a few moments. Sarah Treadwell, social worker from Loft Community Services, a provider out there in the real world, often managing people with mental health conditions. And Emily Lamb is a primary care lead and primary care physician in East York Region and North Durham. Of course, we have Ruth co-leading some of this work, and Nusrat's going to come on today and tell us a little bit about some of the technicalities of providing patient experience supports to the Ontario health teams. So without further ado, Ruth, I will turn this over to you, and you can take it from here.
Thanks, Walter. Welcome, everybody. So we're going to start off with the provider experience survey today as part of the fourth quadrant of the quadruple aim. Next slide, please. And we are very fortunate to have Sarah joining us and Dr. Emily Lamb to give us their perspectives on what their experience in providing care, support for their patients and clients. Dr. Lamb is a family doctor at the Faux practice in Markham and also does home palliative care and is the primary care lead for the East York North Durham OHT. And Sarah is a social worker with the Loft Crosslinks Housing and Support Services located in the Newmarket area. But she wears many hats, is also a care coordinator and also case management for some of the programs, including the outreach services that Loft provides. And so I'm really happy that you can join us and talk to us today about what is important to you as a provider and what you would consider to be a good experience in providing care or support to your patients and clients. And the second thought I'd like you to share with our audience is, if you had a magic wand, what would you change in the healthcare system to make it a great experience for you as a provider? So I'll start with you, Sarah, and what's important to you as a provider?
Well, hello, everyone. You know, I really value working in community services and really meeting people where they are in their own environments and in their own experiences. And I really enjoy doing that. And it's very fulfilling to be able to just provide our clients a space, not necessarily physical, to be reflective of their life and introduce, you know, the notion that they can make change and that we'll support them to do that, and just help them identify options and help them have a voice for that. You know, in regards to healthcare, you know, specifically, that we really hope that everyone can have access to primary health care, and it be holistic. Holistic is a huge basis for how we like to come to our clients, where they're at, you know, like where we really enjoy is to say, hey, can we meet your needs where you're at? How do we, a lot of people who we are servicing are coming out of hospital, are coming without housing and with many services. And we're really picking up, you know, those pieces of what do we need to do, you know? And so we value, we do a lot of work with the hospitals in those transitioning. We do see a lot of gaps in the system of, you know, that flow. And I know that we would really value of how we can look at that better, right from, you know, from the hospital situation, from right there working with the medical teams and then flowing a bit better with that. But we're doing everything we can as a team to be creative and to say, who are you? What's your story? What are some of your dreams? And how do we work on that together? And, you know, it's, yeah, if I were to say I have a magic wand right now, you know, I would look at to say, how do we get more into the hospitals? How do we get in there more if it's, community social workers working more inpatient. I have seen different regions where, they have had case management on site as well as addiction services on site. And so when we're looking at, hey, we're going to transition or discharge, it's not just social workers doing external contacts, it's those community contacts are right working alongside them. So, it's very valuable for us that we have a bit more of a presence of that, those connections, those us teams working together, which we have been working on in York Region a lot. Say, is it addiction services right now? Do they need more peer support? We see how people who can come into the hospital and have suicidal thoughts, and sometimes a Form 1 doesn't always work for them, or they get discharged, and there's a period of a loneliness in there before they can get engaged with services because of wait lists, because sometimes the minimal amounts of opportunity for services, that we're really seeing those little gaps in the flow. And these are questions and conversations we've been having, is how do we work it together? How do we flow it better together so people aren't alone? People know that they have a number, to call. So, maybe a referral is done by social work in hospital, then they're discharged, and there's that sitting period of how do we start working together? How do we get these teams more cohesively, holistically working together? And so that it can flow. And then we're able to provide more opportunity from where they're at, instead of saying, okay, you need some trauma services or you need different counseling, but I'm sorry, but the wait list is a year. And so, right now it's okay, you're at a place where you're ready for change, you're ready to receive support, but they're sitting, so, that's where us who are doing social work in the community are getting really stuck, is we want to work together, we want to be a greater team, but down to, some of these even resources that are needed are done, they need a GP present. We know we're struggling with even getting GP referrals and accepting patients. So getting services is so blocked up sometimes, where it's like, okay, can social workers do some of those applications instead? Can social workers get the ball working, or case managers or different, addiction support services be more involved in that flow? So, I know our team, and we work creatively, as I said, we're looking at how do we work more from the medical at the top, flow better together. Overlapping is very big. We're finding right now that we're needing to create better flow, to keep these people engaged with services and have that care, even if it's more peer support presence. We really value our peer supports, especially in some of those gaps. How do we creatively be like that? And I have, as I said, seen other regions do it, seen other people, and it's like, how do we flow between regions maybe a bit more? Or so for me, and our biggest thing right now with our Magic Wand is, how do we care more together? How do we care more but have more opportunity? Right now we can recognize where we're last getting stuck in community service is our housing struggles. It's not necessarily, I know we're saying housing that meets their affordability needs, but it's okay, maybe they're in transitional housing or supportive housing with the goal of getting those needs met, if it's their care needs, learning some skills, life skills, but what's next for them? And that's where we're getting stuck in our community teams of, where do we go from here? Because, we all know about the affordability, but it's also opportunity for housing for people to feel safe. And safe, affordable housing is an issue for our population that we're working with, because it really puts them in a vulnerable situation where I'm going to say they end up sometimes in some slumlord situations, rent-a-room situations that aren't necessarily legal, but they can maybe afford that on what their income is. So it's that flow that we're looking better. That's our magic wand. That's or, you know, of how do we move someone through the system, but they're still feeling cared. They have a community team supporting them, community opportunities with resources where they can re-engage a bit easier, and then transition out of supportive housing into a safe home, and they can flourish more independently. But then from there, they are safe. They're not vulnerable. They're, you know, and yeah, one of the things I know, having a recent conversation as well, is, you know, we have people in the wait list even to go into treatment. There's a lack of opportunities to go into treatment right now, the long wait lists for addiction treatments. I should clarify, you know, we're seeing a lot of downfall in there because, and then it's, how do we keep these? I know we're being creative as teams. We're being, but this is where we're losing people. This is then they're ending up back in the cycle, back in hospital, back into different services. So there's not an opportunity for them to progress with care. And so then they're, as I said, it's getting back up to the top into medical. And so for us, I know at Loft, we really would love, our magic wand is we would really love to see a better flow, better overlap of care between community and medical. And how do we work together, provide more opportunity between crisis beds, between just opportunities where they can get a little bit more high support, but then they're getting the care that they need to flow through that to what the next level. But at each level, there's not a lot of opportunity. There's minimal beds. There's minimal 2 beds here sometimes for a whole region in one program, you know. So how do we work better at that? Because ultimately, not everyone needs that medical level, but that's where they're having to go to get what they need. And then we're seeing the downfall of that. So how do we put more care into what community opportunities are there, so we can holistically look at a person and meet them where they at, and get them, let them have opportunities to start dreaming again, engaging more, and they're not having to go to the medical level to receive these services.
Thank you, Sarah, for that really sincere, passionate concern for the well-being of the holistic patient and client. Thank you very much. Oops. Dr. Lamb, can you please share with the audience what's important to you to have a good experience as provider giving care to your patients? And if you had a magic wand, what would you do to make the health system better for your patients?
You might need a few magic wands. So, I mean, I'll tell you the 2 main things I would say in terms of provider satisfaction. I mean, one is about the relationship that you have with the patient, and the second thing is working as a coordinated team. So, I mean, delving into the first piece, you know, one of the 4 pillars of family medicine is the idea that the patient-physician relationship is really central for us as a role as a family physician. And it's such a privilege to be able to care for our patients and their families and across a long period of time with them. And, you know, if you ask any of my older colleagues that have been in practice for decades, you know, just a huge amount of satisfaction, you know, seeing, you know, we take care of people from cradle to grave, like quite literally the whole full spectrum. And we see them through some of the darkest times in their lives, through, you know, severe illness, mental health crises. And it's really nice to see them out on the other end. You know, sometimes we see them many times over a short period of time, and then they may disappear from our radar for even like a year or 2, and then they come back. And you can, you know, you can have that follow-up, which is really satisfying. And so, you know, that is probably the best part of my job. And anything that really detracts from that patient-physician relationship, you know, isn't helpful for me, like things like the paperwork aspect. And that's where we see a lot of the burnout, right? Is that we spend the majority of our time now doing paperwork and not actually in front of the patient. And that goes for anything from documentation, which is always, I mean, I'm still struggling whether I document during a patient encounter, because I'm looking at a computer, right, when I'm documenting. And so from a patient perspective, they're perceiving maybe I'm not as interested. And so do I maybe just take jot down a few quick notes, and then if I don't do it during a patient encounter, then I'm spending time then at the end of my day trying to catch up. And then there's forms for everything. There's sick notes, there's forms for physio and massage, there's insurance forms, there's disability tax credits, there's, you know, health assessments to get into long-term care. I mean, just to name a few different ones, there seems to be just a form for everything. And for some reason, it always requires a physician to sign it. And it's repeating the same information. I'm writing the same information about the patient demographics, their medication list, their, you know, past medical history. It's the same thing that's already existing in their chart. So it doesn't, you know, add any, like, it doesn't provide any satisfaction for me to do all of this. And of course, another challenge during our pandemic is, you know, these encounters are now not always in person anymore, right? And so you are taking a little less away from a virtual visit, and then even a telephone call is even more challenging. And one of the benefits we have as family physicians is a lot of this is we've had that pre-existing relationship with the patient. So when I'm talking to them on the phone, I can picture them. I know who they are at least, but, you know, to start a brand new physician-patient relationship during the pandemic via phone, it has been very, very challenging. In terms of a magic wand, if I had a magic wand, I would take away all of the paperwork that we're doing, like everything, all the forms, the sick notes, all the physio, but even the documentation, I would take away that bit, that amount of work that we spend on that. And I mean, I didn't even think that was possible, except for my husband's an IT consultant, and he was doing a virtual Amazon Web Services conference. And I just happened to walk by while they were talking, and it was actually the CEO of one of the healthcare companies down in the States that was talking, and they had a keynote talking about virtual scribes and the use of artificial intelligence and machine learning, where you don't even have to document anything. You do you talk to your patient, you have the conversation, you're going through, you know, what their medical concern is, you know, like something like knee pain. Well, how long have you had it? Does it go anywhere? You know, what makes it better? What makes it worse? And the machine is able to take that entire conversation and actually scribe it into a clinical note for the physician without, you know, without them having to type it all down and summarize it. The AI is able to provide a summary of that. So, I mean, that, so that, I mean, that would be kind of that magic wand piece, is just getting rid of all of that. And the second part, and Sarah touched upon this, is working as a more coordinated team. Because I mean, healthcare is really complex, and we can't do it alone, right? We always have to work as a team across multiple organizations. And it's actually quite satisfying working together as a team. And, you know, especially, you know, some of my home palliative care work, it's a complex system. We have, you know, nurses from different agencies. We have case coordinators from home and community care. Some of our patients end up in and out of hospital. They may have an oncologist that's following them. And right now, there's actually no really easy way of formally communicating between all these team members. We informally communicate, sometimes via text message or phone calls, you know, trying to keep any sort of identifying marker to a minimum, because we know, you know, there's privacy issues with that sort of communication. But it is very satisfying to be able to know that you can just, you know, call the care coordinator, call the nurse that's been visiting, you know, having those regular touch bases. And so, I mean, that coordinated team piece, I mean, it comes back to, you know, having a standard communication platform and having a standardized medical record for all of us. And I think we have to work towards something like that. If I had a magic wand, I would say we have a centralized electronic medical record across the entire province, and that, you know, our EMR systems all would plug into a centralized system to be able to add our notes to a centralized place. Because I mean, this is what our patients almost expect, that this is the case, right? So, you know, if Sarah is seeing one of my patients, it would be really helpful that, you know, I can see Sarah's note, that I know that she's, you know, she's following the patient, that I have her clinical assessment of things, and that, you know, that she's able to contact me and I'm able to contact her if we had any questions or if we wanted to collaborate on something. So that's kind of a high level thing. And Sarah also touched upon housing. I think the more I'm doing family medicine, the more I realize that a lot of the challenges actually lie outside of just the healthcare piece of things, right? It's things that I cannot fix. I cannot write a prescription for it. And that's access, you know, equal access to non-government funded services. So whether it's affordable housing, transit, but even things like counseling, physio, dental, paid sick days, like those are all, you know, huge things that really impact a person's health and well-being that I don't have direct influence over. So, you know, if I had that third magic wand, it would be having that equitable access and improving that social determinants of health for our population.
Thank you so much, Dr. Lamb. You really touched on a lot of areas where we can do a better job, and hopefully with the Ontario Health Team Initiative, we can start being a bit more of an integrated team and not in our separate little sectors. Thank you very much, Dr. Lamb and Sarah, for sharing your insights and what's important to you as a provider and how you would suggest we make some changes to the system to make it better. Thank you. So now we'll move on to the Provider Experience Survey. We did introduce this briefly in our January webinar, and the current measures of out there for providers, predominantly around physician and nurses, and because OHTs are multiple providers across various sectors, we needed to look beyond physicians and nurses and wanted a tool that did resonate with all provider types. And we also found that burnout was a big issue as well in looking at provider satisfaction or experience. So in capturing this the last quadrant of the quadruple aim, we had to encompass multiple dimensions in looking at the experience from the provider's perspective, and also addressing autonomy and their well-being, because in the context of Ontario Health Teams, we are supposed to be thinking as one team across various sectors. And the OHT guidance document operationalizes that providers should have a high level of confidence in the system and that the provider health needs to be supported. So next slide, please. Just quickly, we did the rapid review of the literature and looking for this construct of provider experience from the provider's perspective, not this organizational engagement perspective. We arrived at 5 domains and looked at measures that were really getting at this experience of the provider giving care. A lot of the questions from our survey did end up coming from the RAND physician survey, as well as Gettle and colleagues' relational coordination questions, because again, we're looking at integrated care. We got that down to, but we picked 90 items, and then our team got that down almost in half or below half. We then took it out to field test this survey through focus groups. And that's how Dr. Lamb was invited here. She was in one of our physician focus groups, and Sarah was in one of our social work focus groups. And based on those focus groups, we revised the survey questions, and we then did some pilot testing just to really see how that tool works as if it was live. Next slide, please. So we had roughly 39 items that were asking questions around these 5 domains that came out from the literature. And that was around care coordination, the workplace culture, autonomy, burnout and satisfaction we combined together, and then digital and virtual care, getting at the electronic health records and also delivering care virtually, which is now. Seems to be very, very common and not so new and strange idea anymore. Next slide, please. So in terms of the care coordination, we have some examples here that are questions here that ask about your experience, the providers experiencing the coordination across various providers that their patient or clients receive care from. So things like, how often do you know about all the visits that your patients or clients make to other healthcare providers, including physicians and other healthcare providers? And how often do you feel patient and client care is well coordinated with community services? And then also, when clinically appropriate, how easy is it to obtain a curbside consult from peers or other providers in lieu of referring the patient and getting at the paperwork that Dr. Lamb mentioned? These are asked on a 5-point Likert scale, from never to always. Next slide, please. For workplace culture, this is where most of the questions are, and it's asking to what degree do the following statements reflect the conditions in your work or care setting? Because the culture is important, because low levels of provider engagement are linked with lower quality of care, and that includes safety as well. So examples of some of the questions are, our administrative decision-making process can be described as consensus building. And do you strongly disagree? Out to strongly agree. Again, 5 points. We regularly take time to consider ways to improve how we do things. In my practice care setting, differences of opinion can be voiced and heard. And the leadership in my work setting promotes an environment that makes the work I do enjoyable. Next slide. We have 4 questions about autonomy. And this is, again, a 5-point scale, asking if in your work or care setting, to what extent do you have input into the following things, like the allotment of additional time for difficult to help patients or clients, and the way things are done in your daily work, from you have no extent at all, or you have a great deal of autonomy in doing those things. Next slide, please. In terms of burnout, we have the one question which is validated against the Maslow Burnout Inventory survey, and it's using your own definition of burnout. Please select a statement, and there's 5 statements offered that best describes the situation at work. And then we have some items that get at satisfaction. An example would be that I receive useful information about the quality of care I deliver, and a simple question of overall I'm satisfied with my current job. Next slide. And in terms of digital virtual care, this was an important aspect of providers' experience that was talked about in the focus groups. And we're asking 6 questions and to indicate your agreement with the following questions about digital and virtual care. We rely on electronic information systems to share patient information with other providers. Our electronic health record improves my job satisfaction. And the use of digital methods, be it a video call, telephone, SMS, to communicate, improves the quality of care I deliver. Next slide, please. So in terms of this survey, who should complete it? Well, it should be all the providers that you're going to include in implementing your new OHT's model of care. And when should you start? Well, you should start if you are thinking at the point you're thinking of implementing this new way of delivering care, so that you can get a baseline of where your providers are at. And it's intended to be distributed annually, so that you can monitor how things are going from your provider's perspective as you are doing this new delivery of care. And this data can be used to gauge how well the overall staff wellness is over time. I think that's the end of this part of the presentation. I think Walter has a poll for us, or a discussion question. So we want to know, what are your thoughts on implementing a provider survey amongst those providers involved in implementing your new OHT models of care? So please, I guess there's been lots of chat going on. I haven't really been watching, Walter, so I'm hoping you can share some of that.
There are a couple of questions coming up and a few comments in the chat, and I'll bring these up. So I had asked if Sarah and Emily's comments were reflected in the audience, and a few people had said yes. There's different people think different ways. Picked up on the comments from Emily around AI and getting that kind of data from EMRs. And then also that leads to a lot more open text EMR data as well, which is difficult to actually pull information out of. For example, if you wanted to know which of your patients had a COPD or mental health issues. So I think having codified data as well as free text, and then getting to the point where our AI can pick that up. A couple other comments in here around looking at a shared record from a lifespan approach. I just wonder, Sarah and Emily, I mean, Emily, for sure, you would have a very long relationship with some of your patients. I wonder to what extent that might be true for Sarah as well, but I'll ask Emily, you know, how does knowing that history help? And is that important for others to know? And how does that contribute to your understanding of your patients?
Yeah, that's a good question. I mean, I'm still fairly early in my family practice. I've been with my practice for now 6 years, and I took over for a retiring physician who had the practice for over 30 years. And so, I mean, I'm in a practice that actually, I mean, I think spans about 50 years, because when she started, it was older physicians who were about to retire as well when she started. The benefit of knowing your patients is you know how they're going to present for things, right? You do have a general sense of all the challenges that they might encounter in their lives, and also just how they're able to vocalize their symptoms, and so you know, I mean, I don't want to play into the stereotypes, but if you've got the farmer who like never comes to your clinic to complain about something, and he comes in and he's like, I have a little tingle in my chest, I'm sending them to the emerge. like that, there's something bad going on there. But it also helps to know them through some of the challenges that they might have had in the past, and especially if they've had bad experiences when they've encountered certain things, right? That you're extra sensitive to certain things that might happen. So say like a sensitive female exam or something like that. If you knew that there was a history of trauma, you're going to approach that much differently, right? Than if you didn't know that. So there's a benefit there, and sometimes they end up in hospital, and the poor internists only get that snapshot of them for that little brief period of time in hospital. But we know the entire history of, if other things have happened, we know that medical piece from the background, and sometimes that's helpful to sort out certain things.
well. One thing I will say that has been beneficial is Connecting Ontario, and being able to connect even through hospital notes that way, just to recognize if they have had emergency visits or other contacts. But we're very limited with that. I know it helps when you're looking at a person and them telling their story and experiences. It does give us an opportunity to be more sensitive with that, and that we know people have to sometimes repeat a lot of traumatic experiences. And I think that is sensitive to someone where they are, and gives them an opportunity to not have to be on that repetitive. So, you know, medically, Connecting Ontario is very valuable. I think there needs to be more professionals engaged in that. I know right now it's more within hospital, but if GP somehow got connected with that within limits. But then is there a way for community providers to also participate in that? So that it is case sensitive. We are overlapping more, we are sharing together, because those who we serve have various interactions. If it's social work, if it's medical, if there's more cultural stuff that needs to be sensitive, if there's disabilities, aging issues, the various, you know, our patients and clients have various levels of care that, you know, sometimes we just don't know we're there, or don't know that we can work together, or know, hey, so that's where it creates the gaps. And that's where we end up duplicating at times, or it creates more work. If we're going to go to the burnout, it creates so much work trying to go down the line of who's there, what's there, who's involved, who's not. And it takes up so much time to try and connect the dots and see how do we actually work together and get these care teams together, or, you know, more specialists involved who have benefits, autism services, as well as disability, with the mental health, with how do we all work and connect better to protect the patient, to give them more of a holistic opportunity. And so there's not so much repetitiveness. And so I think it's how do we connect those? Like, I know there's also IAR in place, but honestly, I feel like our team isn't using IAR a whole lot. I think the most tool I feel like we're using more is Connecting Ontario, but I feel like it could be utilized a little better, and could be a greater resource of how we work together, or how do we direct us to who's involved, who's where. You know, also I have patients that will end up in the hospital in crisis and they don't know I exist. You know, when there's a missed opportunity to have the community care case managers involved to speak up, because I'm the one meeting them in their homes. I'm the one seeing them. I'm the one that knows more of the unique situation that might be impacting what their needs are. And I think, you know, these community care, they're just as valuable to provide information and to work with the medical teams to say, this is what's the continued issue. You know, how do we work through this since they're at the medical levels, and so we can surround them with care and support, so that maybe it's not just a hospital thing all the time. It's so I think sometimes there's missed opportunities for them to know if there is other community agencies involved with someone from the hospital. You know, is there a way for them to figure out where those connections are? So I will have a client go to the hospital in crisis, and I don't know Monday morning. I didn't know they went Friday night. I didn't know. And then my appointment, I might not see them for another week. And so I think if there's a better way to somehow connect a little better that we're working, I said, that's where I could see our practices just get a little bit better with them.
Thanks for that very much. And you alluded in there to Connecting Ontario, and there was some commentary, I was going to raise it, around the value of that, but also the lack of access to it. I think once we have systems that are capable of having many points of access, then we can have a conversation about who should have access to what. I think we're having a lot of conversation about what should have access to what without having anything to have access to. Seems a bit theoretical at times. I'm going to go back a little bit and just comment and raise if there's some really interesting pieces. We'll talk a little later in the webinar today about access to the tool and the mechanisms of using it. And there are some comments in here around specific items of differentiating, for example, different modalities of digital health. And that's particularly important on the patient side, which came up in our focus groups, and those will be separated out and we'll see around the questions to providers is more around capabilities. And a little bit about the experience as well. So again, that differentiation can be quite important. There are a number of points around different surveys. So there are comparisons here to Work-Life Pulse, somebody saying it has comparable items and questions, which is great. Hopefully we're capturing some important dimensions here, and others haven't completely missed them. And then there's some people's comment around Christine Babcock talking about doing their employee engagement survey in the fall and thinking about how you're going to time this. I think that will be important considerations. I'll say the questions are in the context of trans provider care. So outside of with coordinating care for patients across the Ontario Health Team with people with other types of providers. Compliments on the panel, good conversation. I want to say, with respect to sharing the letter, Nadine Wallace has asked this question. Perhaps, what are the thoughts around a shared record that the individuals can access, but providers don't necessarily access unless given permission necessarily by the individual? So I think this is an interesting thought around, and I don't want to make this all about patient record for sure, but it is an important component around communication. It's come up a few times, that's the patient's record, and then the providers are given access to it as needed and as they contribute. I don't know what your thoughts on that are, Sarah or Emily, the extent of which there may be patient notes involved as well.
I think that makes sense. I mean, ultimately, it is the patient's record, right? They own the record, but we're housing it, right, more or less as providers. The notes that we have, so having it centralized to a place where the patient can even contribute themselves to their record, right, and be able to deem who can access it. But the key thing is it is really challenging to provide the appropriate care when you don't have all the information that's there. But I recognize the need to balance it with the privacy of the individual as well.
I know that I have regular conversations because I really encourage all participation from my clients, and they very much need to be involved in. It's not we're doing these decisions over them and about them. If we're looking at recovery, it's who you are, what are your goals, and what are we working on here, and who do we need to be involved. And so I think how we structure those conversations, the language we use, I think the care behind them, and I know that we are taking FIPA into consideration and stuff as well. But I think with us, how we have those engaging, that this is about you. This is your story. This is your life. These are your goals. These are your dreams. And, but we have other people involved with this. And so I think it's reshaping sometimes of how we present and how we care for them as an individual. And, because I find a lot of times their first encounters is medically. And so they get used to being talked about or things done behind. And I think it's how do we change this approach of conversation and engagement with them, that they aren't, healthcare isn't just medical. Healthcare is also in the community and other people also providing it in a different capacity, at a different level. And so, but we are working together. And so conversations can look a little different, and know that we're caring for you differently. We're not caring just about you. We're caring for you as a person. And I think with the FIPA in mind, but sometimes I think we need to challenge each other of what those conversations look like, so they feel a bit more empowered to be involved in their healthcare.
Oh, that's an excellent segue into some of the stuff that we're going to talk about in the next part with patients and what's important to them. And I think this collaboration, you mentioned goal-oriented or goals of care, and I would call it important for goal-oriented care. And that's a conversation. And I think that's really important. And then thinking about how are the roles of providers enabling patients to maximize their capability to care for themselves in the, hopefully most of the time that they're on their own. And so I think that's really important. Some of the comments from Jean Thomas around considering IHI's joy of work and framework, and I recommend that reading. We've read it and we're pretty well attuned to some of that material as well. So I want to really thank Ruth for leading this conversation, and Emily and Sarah for taking the time. And I know, Emily, you have a clinic, and one of the things we're always conscious of is that we don't take away from patient care in doing this work. So I know that you won't be able to stay for the entire event, but I just really want to appreciate your time today in coming and sharing your experiences, what's important to it, and grounding our work and participating in your own OHT, but also in helping us at HSPN measure what's important to providers. So Sarah and Emily, thanks very much for your participation. I am going to kick into a poll now, and this one is, and this is not an easy poll for the OHTs. This is one of your challenge polls. I want to know, and I think, I should have gone back to my screen to let you see this before it's up. I want to know, how many providers do you expect to be involved this year, so I'll put it on a calendar year, in delivering care using a new approach developed by your OHT? So I want to know, how many providers are you really going to be engaging in the coming year within your OHT? And you may not be certain, and so you can click unsure, but maybe you have some guess of who you think you're going to be working with and will actually be involved with the care, because from our distance, it's hard to be certain where providers are at in terms of the delivery of new models of care. So I am going to guess we won't have 100% participation on this. Some people on this webinar may not be too clear or sure. You could click the unsure box. And in 5 seconds, I'll leave this up. And we'll come back, and it's good for us to have a sense then of, what's the capability and what are going to be the expectations of us to help support you in this work. Okay, I'm going to share these results back out with you, and now you can see that that almost half are unsure exactly where, but still quite a few people. So 10 to 24 moderate sized groups, that's a quarter of our respondents, followed by 1 to 9 smaller starts. And we're thinking about all of the people are going to be directly involved this year in delivering new models of care. Remember, most of your work to date seems to us to have been planning. So we're very interested to see, how is this going to land and who is it going to land with? So that was a little bit of a challenge question for you, and very important to us, because we need to know what the expectations might be for us coming up. So again, thanks, Emily and Sarah. We're going to turn now to our work in developing a patient experience survey to measure the third quadrant. If providers are the fourth, we'll got to have a third quadrant of the quadruple aim. And I am very, very pleased that today joining us is Chloe Gallagher, who is Chloe survived a hemorrhagic stroke at a younger age, although she is still quite young, and is a patient partner with the Burlington, Ontario Health Team. She's a patient advisor to the Brant Hospital in their PFAC, but she actually describes herself as a patient partner in the Burlington OHT. That's a misnomer on my part. And I think Burlington, we feel, has been genuine, very genuine in their engagement of patients in designing and developing their OHT, as have many others in the province, but certainly one of the ones to stand out. Chloe is also an epilepsy South Central Ontario ambassador, so quite involved and has been a great contributor to our work, and really a wonderful person. Chloe's going to start off, I think, by sharing just a little bit about her experience in the health system as a patient. Go ahead, Chloe.
Hi, that was a very nice introduction. I just wanted to thank Dr. Lamb and Sarah also for everything they contributed. That was very helpful and really kind providers, so thank you. Anyways, what has everything that has happened? So I had an undiagnosed arteriovenous malformation, or an AVM, rupture when I was 15, which led to a hemorrhagic stroke and in a coma for a little bit. And since then, I've had over 10 brain surgeries and was diagnosed with epilepsy. And everything is under control now, fingers crossed. And I'm an ambassador for Epilepsy South Central Ontario. I did a few years of nursing at McMaster, but had to withdraw from that to have some surgery, as well as a year of PSW at Mohawk, but also withdrew from that for some surgery. But I'm hoping to eventually re-enroll at McMaster to finish my nursing and go on to work in healthcare one day. But I am loving being a part of healthcare right now as a patient partner with the Burlington OHT, and appreciate that opportunity and everything that we're doing with engagement, and love just OHT in general and all the engagement they're doing with patients, and taking all of our advice and feedback genuinely. It's really been helpful and great to see.
Thanks, Chloe, for that introduction. And it's really, you've had quite a bit of experience. I wonder if you could tell us a little bit about, and we've sought this advice from others, but maybe just from you today, on what's most important to you about your experience, and if you're having a good experience, what are some of the features that contribute to that you could describe?
I would say that during my experience, since it happened when I was 15, I was technically pediatrics and spent a large portion of that time at McMaster Children's Hospital, and then eventually went on to Hamilton General, and eventually a lot of my care has been in London at University Hospital. But that transition from peds to adults can often be a scary one, and I'm not sure if any patients can relate to that, or doctors or family members and caregivers. But if you don't have that support from your doctors or family, sometimes you're just left with, okay, here you go, this is your new doctor, and you're just kind of kicked out of that peds system, and you're an adult now and you don't really know what's going on. And I was very fortunate that my surgeons really introduced me to my new surgeon and my new practitioners, and that communication was very strong, and I was very thankful for that. And we're very lucky to have a family doctor who literally delivered me and has been with me through my whole life, and I know I'm lucky to have that. So I have been very thankful in that sense. But in regards to a great experience for me, and I think for many others, would be just fantastic communication. And when it comes down to it, communication, as many people have noted, is a key part of healthcare. And it's not just communication between you and a provider. It is providers communicating with each other. It is like communication between not only like your doctors and providers and your caregivers and your family members, so that they also know what's going on. I mean, with respect to you wanting them to be informed, that's important, that boundary is not being broken if you've said that you don't want them to be informed. But if they, maybe I know I've had instances where if I'm like in a coma or induced coma or whatever it may be, they're advocating for me at that time. So if that flow of communication isn't there, then that's not okay. But I know all of the instances where communication isn't happening between doctors, not only is that frustrating for me and for doctors, that is also a safety issue. If medications aren't being relayed correctly, or radiology reports or what have you, that can be a large safety issue for patients, right? So whatever means of communication it may be, a positive interaction with that to answer your question in a long way, that's a great patient interaction and provider interaction for me. And I think that providers probably appreciate that as well.
It brings to mind right now for me, it's a really important component, but also actually something that's suffered a fair bit for people, certainly people in acute care in the past year. And I know I've heard it from multiple sides. Personal experience, my sister's husband was in for CT for he's a cancer survivor and still some ongoing issues, and not being able to be in there with him in meeting. And when they get back home, she's the one who keeps them straight on what he's supposed to be up to do. And so that's a real gap. And we've heard it, a short time ago, I was having a conversation with the neurosurgeon around stroke patients. And when a stroke patient's in the hospital, they are not communicative. And if the caregivers are not there to actually be able to tell what that patient's experiencing, then the providers are at a bit of a loss, and they're left to a communication on a phone call maybe at the end of the day with the family. So it just has highlighted the importance of that component as well. When, as you say, it's in the patient's interest. So I'm sure you could go on for more aspects of experience, and I'm sure that we're handing you a magic wand. Emily wanted a genie bottle. But maybe if you had just one or two things that you would put it at the top of your list of things that you would really like to see changed, or that could, in your experience, make improvements maybe in Burlington or maybe elsewhere in Ontario that you're aware of.
With a magic wand?
Yes.
Okay. My magic wand is not possible, but I would love this. I think one thing I would do with a magic wand is just time. I think we could give patients time and providers time, and this whole system just needs time. Whether that be, think about, I know that it is stretched so thin. I know generally, an appointment with your GP is a 10-15 minutes, and you can tell that they want to spend longer time with you. And I know sometimes they are booked for longer, whatever it may be. I'm fortunate that if I'm in crisis with, mental health or maybe I got a bad diagnosis and the GP knows they need to spend longer with you, they will take that time. But right now, they don't have the time, they don't have the capability right now. And I'm sure patients would love that time, right? And another thing I think of when I think of time is how many times in our life, in a patient's life, in a doctor's life, how we all said, what would be great if, our surgeon and our neurologist and the GP and the radiologist could all just sit down in a room, in a meeting room, and just say, hey, how did that appointment go? So what do you think? And what's your opinion? And just all sit together as a family, as a patient, everyone, and just take 10 minutes and all get on the same page. No one has time for that. I understand that. I think everyone understands that. But if we could have the time to do that, it would save a lot of stress. It would save a lot of confusion. And frankly, it could probably save some lives, again, because of patient safety and just things falling through the cracks. Because otherwise, there's times where, you sit there and you're like, well, Dr. X said this and Dr. Y said this. And then all the doctors are on the phone like, hey, why did you give her that diagnosis? That's not my opinion. And again, I understand that there's different opinions, but as much as it's great to get those different opinions, it can also be very confusing for the patients and very confusing for their families. And, at a time of crisis, especially, I can't imagine if you have like a very young child or in the midst of a very, very serious situation, if everyone could just pause for a moment. Time is my magic wand. Also with, you know, referrals taking months, and now after COVID, years time. And that goes back to, you know, what our providers were saying, the wait times. I'm sure they would love that coordination. So it's not just my patient magic wand. I'm sure it's everyone in the system's magic wand.
Well, I'll say that the chat is like a fire with people agreeing and having ideas and thoughts around this space. And I think it also gets back to communication. So I think, you know, multidisciplinary conferences, team conferences are, you know, I'm fortunate, I don't need one. But for people who have many different care providers, I think having that organization can be very important. And there's a note in here: time well spent, more valuable than time lost, from Marie-Josée Lafontaine. Thank you. I think, you know, when it's needed and there are multiple different people involved in care, it can be essential to figure out how to make that time happen, particularly around case conferencing. Of course, we're also pressured by time today. I had
if I can. Oh, could I say one thing?
Great. You're great, but we're gonna. But I'd love to hear more, and I'd love to give a lot more time to other patients today. And I'll watch in the chat, but we are going to go out, and I'm going to provide a little bit of background on our survey now. Thanks so much, Chloe, for sharing your story, and I think emphasizing what's important to you and to patients.
Could I say one quick thing?
Yeah, absolutely.
Okay, one exciting thing that we're doing in the Burlington OHT, we have various action tables, and one of them that I sit on is called the Care Transition Action Table. So we're looking at really making sure that people don't fall through the cracks. So like how we're transitioning from Emerge to like your family doctor, or from community care to family practice, and vice versa. So I think that's like a care coordination kind of example, like things that we've been talking about. And I'm just really excited that we're doing that. And that's sort of taking the time, right? And that's just when I reflect on time, I think that's an aspect that's important. And we're taking the time, and we're taking that care coordination. And like I said, I'm just excited about like OHTs and taking the patient engagement and the feedback. And I hope other patient partners and advisors keep our fingers crossed that all this engagement continues and we all work together, and maybe we can break down those silos, and maybe these surveys will help, and we can all do this. I'm going to be optimistic about it, Walter.
Excellent.
I think we can do it.
I'm glad to see your optimism, and maybe you could have a chat, and feel welcome, actually, even Chloe yourself, to come into the chat. You know, Anne-Marie Erskovich, also one of our focus groups, thanking you. Caroline Alloway, I do a lot of work with on there. And there are a number of places. Transitions were one of the places that were mentioned. Increased use of care coordination. Care transitions are an interest to us in capturing in the survey as well. And I think that that's a real opportunity for communication and for people to spend time organizing that better. It's not always time with patients, sometimes just time to take with the patients and providers together to work out what the model really needs to be to best meet individual patient needs. Okay, thanks again, Chloe. That was really rich. Thank you very much. I appreciate it so much. So what are we going to do about this, and how can we help OHTs keep an idea and a focus? So many people already have measures of patient satisfaction out there. There are hospital surveys, there are primary care surveys, there are home care surveys. There is even something in Ontario called the Healthcare Experience Survey. But I think those are primarily focused on events and particular points in time in a patient journey. And one of the things we were very interested in here is to be able to capture the patient experience domain of the quadruple aim, reflective of coordination and integration of care that would be applicable to all patient groups and encompass multiple dimensions of care across providers. Our work was developed in the context of integrated care, and it's being applied to the context of Ontario health teams. For those that were here in January for our webinar, You would have seen, we spent some time with Carrie Koleski, who led this practice guide on how can we better understand and meet the needs of patients and caregivers. This is available on our website. And it comes up with kind of core dimensions across a number of domains here. And so the first of these, just to make it a little bit bigger for people to see, is this starting inside this easily access health and social care. If you can't access, not much point in talking about experience. And that is the first point of experience, is access. And then inside, it's about having someone to count on, being heard, and these lead to knowing how to manage health. So these are all topics that we've talked about today in a couple of different ways. And the outcomes of this is really that people can be independent, and in the words of our some of our patients in some focus groups, also about well-being. And part of that is also feeling safe. So how did we end up with a survey tool here? This is a bit of our development process. You know, we have across our team, much of this work, always collaborating with Carrie Koleski, much of it led with her. She's a research chair in patient and family experience. So there were over 175 1+ hour interviews with patients and caregivers across multiple jurisdictions, and an extensive qualitative analysis. You can just imagine how much data that provides. And that's what really led to those 4 processes and outcomes. Those are about values and what is valued. A couple other projects that we've been involved in in home care in Ontario, we were involved in, it was a 4-part project. We did an extensive analysis of the existing experience tool. Then we also had a literature and gray and academic literature review. We had 12 or more client and caregiver engagements across Ontario of people who were involved in home community care. And then we actually came up with an instrument and did field testing, both with a client and separately for a caregiver tool. This work was supported by Health Quality Ontario in the day, Ontario Health Now. Bernadette was very much part of it. She's online. Then we've also done other evaluations where we've used patient experience and sometimes caregiver experience surveys too. And in this, we've learned both a little bit about tools, but also about how to use this to provide feedback to providers on an ongoing basis. And we did it quite actively in bundled care. And we had one region in Ontario that came along with us to look at patient experience in HealthLinks, which was quite an enlightening experience for them. For now, in this work, we created a set of items, and these we've been collecting data in, oops, that pilot testing was not with GPs, that was with families and caregivers, and reviewed the survey based on feedback. We also had, I think Ruth, that validation side on yours had mine. I think we flipped those. We also, so aside from the focus groups, we've also had some field testing with some of these items in the healthcare experience survey in Ontario. So we've seen some of the data to know what kinds of responses we might get back. So here are the domains, and I am going to go through this quite quickly. You can review the slides and also the webinar after to get a bit better of a sense. So as you see, the first 6 of these are drawn right out of that framework: easily accessing care, having someone to count on, being heard, knowing how to manage health, and independence and well-being, and feeling safe. To this, we have been very cognizant, as Chloe intended, and many others have as well, the importance of transitions in particular. And so we have a focus on a few transitions specifically, and then some overall health questions. Getting back to the first question I had from the January webinar, how are we measuring health? Well, we'll see, we actually do have a health measure in here, and sociodemographics as well. So hearkening back to that question from January. Some of the questions that we have, and I might skip over a few of these, the experience with care coordination. So for easily accessing health and social care, we're interested in the accessibility and the coordination as well. So we have some access questions about your being able to have primary care access. But here I've highlighted, when you consider how you and your healthcare providers help you take care of your health, how coordinated you say your overall healthcare is. And again, this is about, that accessibility is also about accessibility to coordinated care, not just individuals. When it comes to having someone to count on, one of the ways we thought that this would be exemplified is if people actually check to see that you receive the care that you need. And that's what this question is. How confident are you that your usual provider of care or other healthcare professional checks to make sure that you receive the healthcare you needed after their appointment? So following up, and someone you can count on will do that. Around being heard, we have multiple items in each of these, but I'm just highlighting out one. When you see your usual provider of care or someone else in their office, how often do they involve you as much as you want to be in the decisions about your care and treatment? You know, this is a question, we've looked at tools around the world, and this is a question that in places that are really trying to be more patient focused and person focused in their care, that this is something that comes up a lot. I think it's really important to people. And then knowing how to manage your health. Is the supports that you receive from patients and providers, from the providers that are caring for you, did they give you conflicting information? And Chloe mentioned this, like, are they on the same page? Are they telling you different things because they have different opinions? Well, at the end of the day, it's very confusing, and there needs to be some common view of what's important. We have a couple questions around health conditions and well-being, and then we have experience around safety. You're able to move around your home and neighborhood without fear of falling. And we finally have some of these transitions questions. If you were treated in an emergency department, then you'd respond to a question. When you left the emergency department, how confident were you that you had the information you needed to care for and manage the health problem? Or if you went to see a specialist physician or provider, after you saw the specialist, did your usual healthcare provider seem informed and up to date about the care you got from the specialist? We also ask specifically about information flow back and forth between those providers, as well as availability of tests. We're using the Euroqual 5-dimension 5-level measure for overall health. This is a health-related quality of life measure, and it covers off domains of mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. It's the most widely international used tool. It's just 5 items, and it ranges from no problems to being at the extreme end of having difficulties and challenges. We'll also have some sociodemographics, including socioeconomics around income, food, housing, security, as well as social isolation and loneliness, and the same ethnicity question that we're using in the provider tool. People want to know about the tactics. So I feel that we're going to move on to make sure so you have an understanding about how we're going to do this. Please stay active in the chat, and we'll bring that back next month, maybe to an extended Q&A session. And we'll also follow up in the chat because we really want to know about your experience, and I'm cognizant of about 5 minutes left. So I'm going to turn it over to Nusrat just to go through some of the process of this, and I will check into the chat to see if there are other points I can be responding to. I can see there are 20 or more comments since I last looked. So Nusrat, I'll turn it over to you.
Thank you. So the way we intend to administer this, the standard operating procedure would be that the survey package would be sent from us to the OHT contact, whoever was listed in the application as the evaluation contact, unless you have emailed us to let us know that the contact has been updated. You will be receiving a general user link for the provider experience survey as well as the patient experience survey, but I'm just using the provider one as an example, but pretty much both go through the same steps. Well, technically it would be 2 links because it would be available in both French and English. A Word doc file with suggested wording for the survey invitation so that OHTs could take it upon themselves, modify the language as they see fit, to email the survey to providers, patients, as well as a PDF information letter regarding research participants' rights, information, who to contact, and a PDF of everything that I'm about to tell you in clearly laid out step by step in both languages so that you can refer back to it. Next slide, please. So for the provider experience survey, it will be running for a 3-week period, 6 weeks period, apologies. So once you are ready, just let us know and we will send you the survey package. And once the OHT distributes the survey out, we request that you email us back to let us know that you have done so. That day marks time 0. And from then on, 4 weeks later, we will provide all OHTs with a response count per OHT so that you know what your response rate is like. And we encourage you to send reminders to all of your providers to let them know that they only have 2 weeks left for the survey to close. And at the end of that, at the end of 6 weeks, we will provide you with a data pool for your OHT, provided that there are 10 or more participants for privacy reasons. Next slide, please. For patients, it's pretty much the same thing, except after the 6-week period, the 6-week data pool marks the baseline data, and since it's an ongoing process, every 3 months we will pull another, like the newer set of data, provided again that you have 10 or more new respondents. So that is pretty much the only difference between the patient experience survey and the provider experience survey. Next slide, please. So just to orient everyone to our platform, we are using RedCap, and when you use the link, it will show up with this. So we leave it up to you as to how you would like to field the survey. You can also, if you wanted to, have a paper version, which is also available on our website, PDF in both French and English for you to download and administer how you want. But the information letter, all of that is up to you how you want to distribute it, but we just want to make sure that providers and patients have read and understood the information letter. So once you have that, they can just click yes. But one thing I just would like to let you know is that for those who are hearing impaired, RedCap does offer speech enabling, so they can click on enable speech and it will be read out loud for those who are visually impaired, sorry. Next slide, please. So yeah, so this is the I guess, second page technically, where patients and providers get a little bit more information regarding how the survey works. That takes 15 minutes, and to just let us know which OHT they're a part of and which what their email address is. And if you don't have an email address, for example, let's say in cases where you're working with a homeless population, but OHTs can, for example, print out a paper copy, give it to a patient, the patient gives it back to them when they're entering it. The email field just accepts any generic email address. So you could just put, jane.doe@noemail.com and it will register as such. So it's not that you need a valid email address, but it's just a way to keep track of who has answered, who hasn't. Next question, next slide, please. So this is, a very standard way it works. Multiple choice questions and certain, if you click other, we will ask you to specify, and you can also resize the font, by the way, again, for those who are visually impaired. Next slide. And for the provider survey, a lot of it is in this form of, as Ruth mentioned, never, rarely, sometimes, and it comes in a matrix question. So we do suggest that you do this on a desktop just to see everything clearly, but it is also mobile friendly. Next slide. And so when we give you the data, this is what the data will look like. We will remove any identifiers, so the email addresses, the timestamp, record ID, we will remove all of that for privacy reasons. But what you will get is a record ID that I will have created, just numbering 1, 2, 3, 4, 5. And then it'll start with current role and all of the initial questions regarding things such as, if they're full-time, et cetera. And then this is an example of the types of substantial questions. So it will have the full question along with the full answer. It won't be codified as to 1, 2, 3, 4. It will be actually rarely, sometimes, et cetera. So you guys can code it however you want. Next slide.
So I think that's right. That must have been the end of that piece.
There was just, if you could just quickly go back, I just wanted to mention one more thing. One more time, I think.
More back?
Yeah. Oh, okay. Never mind. There was something else. It's okay.
Okay. Sorry about that. And I just want to thank you, Nusrat, for summarizing that very clearly for us in 4 minutes. We had intended for it to be a little longer than that, so apologies for that being a little bit more abrupt than anticipated. We'll make sure this is again well communicated. There were some questions in the chat. We've tried to answer a few of them rapidly. Appreciate that we are over time. We still have 200 people engaged, so even though we've run past our time, really appreciate your engagement. We're not really empowered to do this. We're doing it because we think it's important. So it's been a bit of a labor of love, really we couldn't do quadruple aim. When we looked at it, what was in the quadruple aim for patient experience and provider experience a 1.5 to 2 years ago when we started this journey, we saw 3 big letters, TBD, and that just wasn't going to cut it. So we have put in quite a bit of effort to come up with a few tools. We've had a lot of engagements with providers and with patients along the way to do the best first crack at this that we can. And we're going to make it available, and we will make it available for you to use yourselves or through our portal and platform so that you can actually have providers and patients and have that data to start to inform your work in this year. So the tools will be made available. We'll be making very broad announcements of when they are. The provider tool, as you can see, is already online. We still have a few more tweaks on the patient given some of the feedback we have from patient focus groups that is being incorporated, and also to get proper French translations on both tools. So we thank you very, very much, everybody, for your participation today, for your engagement, and we hope that this will be a useful starting point for us to be measuring patient and provider experience in a common way, in a non-provider specific way. This is about patients, what's important to them, and about providers and what's important to them. Thanks for joining us today. The webinar will be available online along with the slides, and feel free to get in touch. I'm sure you'll have questions. Maybe pause a week on the questions till we can get some information out to you in a more distributed way. But do feel free to send your questions. We're really happy to help you here. Thanks, everybody. Have a lovely afternoon, at least where I am. It's quite warm. There's a feedback link, and you'll also be getting an email. Please give us feedback on these events. Clearly, we need to time manage a little bit better. Chloe, more time. Thanks, everyone.